first stage. We're assessing those vital signs, and we have them on continuous. Okay, we have them hooked up to telemetry monitor. We might have them hooked up to the defibrillator. Depends on what their situation is. Okay, and then we're monitoring that urine output because we want to know how much urine they're producing. We want to know if they're in what impairing state. Okay. Let's answer this question. Think about the very first thing okay, he or she will do. And you're gonna apply oxygen. Remember, Lisa makes it first. Okay?
Is it 2 liters per minute? Just to increase it.
Say it again.
Oh, okay, so in the question it said 2 liters per minute, and then respiratory rate is 24 breaths a minute. I thought if you give them more oxygen, it increases their
That's for
respiration.
that's for COPD. That's what but read your answer choice. You have an order because it says as ordered. Okay?
So another kind of
So as a
question.
nurse, you can only give 2 liters.
So another kind of question you assume because it says as ordered that there's an order.
But it tells you it's an
But
order.
I mean that's where you have to look at it like, okay.
It tells you that's an as ordered. You see what I'm saying? Any place is not gonna lead you to this. Okay? If it says apply 4 liters of oxygen, you're not a doctor, you have to say things. But if it says as ordered, you have to do it. Okay?
Oh, okay, so even if the answer choice says that and the question doesn't have that nowhere in there, then it could still be an answer.
I wanna help you, guide you with what you're thinking. Now, you're asking me why you're giving 4 liters? Think about it, they're on 2 liters already and they're breathing labor, 24 breaths a minute. That's high, okay? So the first thing you're gonna do is what? Increase, cause you gotta think about it, what is it? They have stable angina, so that's something we already know, okay? 7 a.m. their vital signs was, they were 2 liters of oxygen, they were cannula, 10 a.m. chest pain again, okay? Think about the chest pain, think about Mona.
Is that
Hmm?
the same as hyperventilating?
No, not yet, almost, but they're on their way because they're struggling to make oxygen.
Mona,
Okay.
what was the acronym for?
So I hope what I said kind of helped you.
Yeah.
Don't overthink it, but think about why they're here, think about that disease process, think about how we treat it.
What's page
Okay?
now?
Morphine, oxygen, nitrates, and
Mm.
acid. So it is, okay? So the chest pain, well, they were going more into something else, so read the rest of them. Yeah. Morphine, oxygen, you can get oxygen. And nitrates, so you can do it for angina, because it's still the chest pain, okay? Let's answer this question. she already found the correct answer. Second guess it. Don't second guess yourself. You all have the knowledge, okay? So, the continuum of sepsis, okay? So when we start talking about sepsis, sepsis is what? There's an infection invading the patient's body, okay? It goes from SIRS to sepsis, severe sepsis, septic shock, and mold. Now, SIRS is that systemic inflammatory response to the insult. The body is trying to fight off whatever this invasion is that's happening to you. So they're going to be some signs and symptoms. Inflammation is what? One of those precursors to any type of invasion, okay? The organs usually remote of the insult are going to start getting inflamed, okay? Now, the syndrome, again, like I said, infection, it progresses to bacteremia, the infection in the blood, and it's blood circulating through the system. Then it's sepsis, severe sepsis, and then septic shock, okay? And then finally, multi-organ dysfunction syndrome, where all the organs start to shut down, okay? And when it gets to mold, the prognosis is poor because you're in a hurry, you're in a race against time to secure all of the organs that we won't shut down, okay? Now, we want to prevent the progression of SIRS to mold. We don't even want it to get to mold, okay? Where the organs start shutting down. So, you're gonna do prevention, okay? So you're monitoring them. They're usually in a high acuity setting, like IMU or ICU, and you're monitoring them closely. Subtle changes for heart rate, blood pressure, you're looking for that widening pulse pressure, okay? OT-SAT, respiratory rate, urinary output, and then the central neurological center changes. So the CNS changes. So you're doing a neurological assessment, okay? You're assessing PERLA. Are they awake, alert, and oriented to person, place, time, and purpose? Okay. You're checking for the hand strength and grasp. You're doing it for the feet, push and pull. Okay. So again, like I'm saying, you're assessing their neurological status as well, because when that oxygen starts decreasing to the brain, what? You start seeing those neurological symptoms. Okay. Now, prevention and treatment of infection. How do we treat infections?
Antibiotics.
Okay, but as a nurse, as a healthcare provider, what is the first thing you want to do before you give antibiotics?
Ask for allergies.
They're in the hospital. You assess for allergies. You know, you've admitted them. Wash your hands. The doctor is giving you orders. He's ordered antibiotics. What would you anticipate? What order would he give you first? Blood cultures, yes. Because you want to find out what the organism is, okay? We know blood cultures take about, 72 hours before they result. And then we give them a broad spectrum antibiotic. But we want to do blood cultures before the antibiotic is given, okay? So, again, broad spectrum antibiotics within 1 to 3 hours of admission. But we're doing those blood cultures first. We want to maintain that tissue oxygenation, nutritional and metabolic support, okay? And support of each individual patient's organ. So, let's talk about DIC, disseminated intravascular coagulation. Okay? Does anybody in here know anyone that has had DIC before? Okay? DIC can happen, it can happen in pregnancy, okay? With women after they've given birth. So, DIC is a serious, we call it a disorder of homeostasis because of overstimulation of the clotting factors, then followed by anti-clotting. So, what did I say the first thing is that starts with DIC? Overstimulation of clotting. Okay, so how do we treat DIC?
What?
Anticoagulants, like what type?
Warfarin, heparin.
Heparin is the first line because you have overstimulation of clotting. If you can stop those clots from the beginning, you can stop it from progressing to deacidic. Okay? So, that's why we said that the treatment sometimes is paradoxical, okay? Because it's heparin, and you're giving heparin to stop a bleeding disease, okay? But again, the beginning starts the overstimulation of clotting factors. How do we test the blood to see for clotting?
PTT.
We can go PTT, INR, but that's gonna tell us how thin the blood is. How do we know about clotting? D-dimer. The D-dimer
Oh, yeah,
is gonna check the fiber level in the blood that reduces
Yep.
the
I
clotting.
do. I had it 5 times.
So again, there's faster clotting, decreasing clotting factors, platelets then occurs, then the hemorrhage and more clots, and then the accident. So again, we kind of talked about this, the uncontrolled hemorrhage, early detection of bleeding, occult and overt bleeding, okay? We might riot the stool, to see if there's any occult blood in the stool. Now, if a patient has BIC, they can bleed from where?
Anywhere.
Any orifice, okay? Gums, eyes, okay, anywhere, okay? So we're checking for any of that type of bleeding. We're checking our D-dimer, like I said, to measure the degree of fibrinolysis in the blood, okay? Because that's gonna tell us about those clots. And again, we're assessing for any signs of internal bleeding as well. And again, you want to be sure. Heparin needs to be checked by 2 licensed nurses because that's considered one of those high alert drugs. Okay? Now, if we need to give blood products, we'll give PRBCs, FFPs, even cryoprecipitate. That will be administered by the Army. Okay? Now, when we're looking at ARDS, acute respiratory distress syndrome, like I said, we need oxygen, okay, one of those basic level needs. ARDS is a severe form of respiratory failure. So your patient is gonna have hypoxemia, okay? So we need to find out what the insult is, okay? Now, we want to, what caused it, we wanna make sure we can keep our patient oxygenated, okay? We'll do chest x-rays to find out what's going on in the pulmonary and the lungs, okay? Now the alveolar in the lungs, their job is gas exchange, okay? But if something's going on in the pulmonary spaces, like a fluid, thick mucus, exudate, they might collapse, okay? They can't do that gas exchange, they can't do their job appropriately. So again, as ARDS progresses, we have alveolar capillary membrane damage with subsequent leakage of fluids into the interstitial spaces and the alveolar. Let me show you a picture of this, okay? So this is what it can look like. If the interstitial, okay, starts filling up with fluid or mucus and exudate, it will collapse the alveolus. And like I said, their job is gas exchange, okay? So it'll lead to, because it can't do the gas exchange, hypoxemia, dyspnea, scattered crackles, so you won't listen to the lung sounds, in all the areas, anterior and posterior, okay? And you're looking at the patient, they might be using their intercostals with that extra work of breathing. Okay? Respiratory acidosis will occur early. Then you have pleural effusions that can occur, decreased cardiac output, and cyanosis. So your overall goal, like I said, keep them oxygenated. You want the PaO2 up at least 60, okay? And that's when they're in the recovery phase. Adequate lung ventilation to maintain a normal pH, and then recovering them, PaO2 within normal limits, O2 sat greater than 90%, patent airway, and clear lungs on auscultation. When we're looking at delirium, okay, for elderly patients especially, it can indicate an impending change in their condition. So, especially like it says up here, urinary tract infections. It can cause delirium in our elderly population really quick, okay? So, other risk factors for delirium: sleep deprivation, hearing impairment, opioids, corticosteroids, drug or alcohol abuse, like I said, UTIs, fluid electrolyte imbalance, and then post-op, being in the ICU that can develop emergent delirium or ICU psychosis, okay? When we look at prevention as the nurse, what are we gonna do? You're monitoring their neurological status. You're doing that neural assessment that I talked to y'all about. Are they awake, alert, and oriented to person, place, time, and purpose? You're also doing Perla. And you want to provide calming, reassuring environment for them. Okay? If they ignore you, you're going to open the curtains, help them with their activities of daily living, dressing, brushing teeth, combing hair, lunch, dinner, breakfast, lunch, and dinner. You're going to encourage family to be present and supportive, okay? The doctor may order medications like Haldol, okay? Or haloperidol, same drug, just the name. It's a neuroleptic drug, okay? It can help calm the patient. Now, you want to, again, encourage family support for delirium. Let's answer this question. Correct answer is 3. Respiratory rate, 25 breaths a minute. Okay? The respiratory rate is high. Let's answer this question. Positive question. We're looking at the highest priority. Okay. Okay. All right. Correct answer is 2. Rolling highest priority. Okay. That question?
I was just surprised that if the fever's that high, you'd be worried about like the seizure rate.
Well, you want to hurry up and do it, and think about it. In places like real world, but our highest priority is getting the blood cultures. You know, to find out what's going on. Okay. You know you're gonna have help in there. It's an emergency situation, but the blood cultures are priority. Somebody else can be doing something else, but the priority is gonna be getting those cultures. All right. So tell me what your name is.
Me?
Yeah.
Victoria.
So Victoria, that was your patient, and you're in your room, and you want to know why. You're gonna call somebody else in there to help you do the other stuff, but you wouldn't get those cultures in that quick. Okay? Because sometimes those broad spectrums, they don't really work, okay? But when you get those cultures back, it'll tell you exactly what it is, so you know exactly what drug is gonna work for the patient, okay? Correct answer is 2. Notify the healthcare provider. This is emergency. Okay? life support, like I said earlier, we do compressions first. Okay? You find the patient down, we're giving high quality chest compressions, we're pushing hard and fast. And adult compressions are 100 to 120 compressions a minute. What song are we using?
Stay alive.
No, we're using a new song now.
Oh, not me.
Everybody know what it is? Baby Shark? Everybody know Baby Shark?
Baby shark, baby.
Baby Shark works, but I'm a CPR instructor too. I teach my students all single legs. Because that is gonna get you what, 120 compressions and a fat, and you know, we've talked about all single legs, it gives you that 120 compressions fast. Cause think of it. How many seconds are in 1 minute? 60, okay? And so what, if within 2 minutes, and 2 minutes goes quick, you need to have those high compressions at 100 to 120. Simply because the reason we changed it to compressions first is because we were saving bodies and not brains, okay? And so depending on the size of your patient, you got to be sure you're doing those high quality compressions because you are the pump now, okay? The heart's not pumping, you are the pump, okay? So you gotta remember that. Now, if you're in a hospital setting, you assess the patient, you determine they're unresponsive, call for your emergency system, the AED, okay? Press the code button so you can get the AED in there quick, okay? The quicker we get the AED there, the patient hooked up to it to see if we need to deliver a shot, the better outcome for the patient, okay? So, having said all of that, after 30 compressions, we open the airway, we do that head tilt, chin lift, and ventilate with the bag valve mask. You're gonna provide 2 breaths each over 1 second. You're looking for complete rise and fall of the chest, okay? Now, having said that, you have your defibrillator. You're the one who found the patient down. If you're the nurse, you will never leave your patient, okay? You're gonna call for all the help you need. Unless you need to run out and call, you can't call, and you need to just run out and say, well, or I need the crash cart or AED or whatever, okay? But you should never leave your patient, all right? Now, you apply the AED, apply the quick look paddles, you're gonna do exactly what it says. Of course, you say, I'm clear, you're clear, everybody clear. If it says deliver the shot, you deliver the shot. You assess and see what it says, and then resume CPR if it says, okay? For small neonates and infants. For babies, how long has it been since y'all had pee? Mother baby. Y'all are there now, okay. So with neonates, just remember, they can be born hypoxic, okay, or hypoglycemic. These are two of the top 2 reasons a baby will need resuscitation, okay? Also, there is hypothermia, because their temperature won't normalize outside of the womb. There's also acidosis and hypercoagulability. Jaundice. For children, we look at respiratory arrest, okay? Prolonged hypoxemia secondary to respiratory insult or shock, including septic shock with children. And then the guidelines are gonna vary on the child, but again, you're gonna call the code and get the AED. For children, infants less than 1 year, we're assessing the brachial pulse. Children that are 1 year and older, we're assessing the carotid and the femoral. Okay? So you wanna know that. Compressions need to begin within 10 seconds. Infant compressions, you're covering, using both hands, 1/3 of the anterior posterior diameter of the chest, and you're doing 1.5 inches in depth. That's infants. With children, 1/3 anterior posterior diameter of the chest, but your depth is 2 inches, and you're delivering each breath over 1 second. Let's answer this question. And you could just, I'll let you just write these down somewhere in the corner of your book, your answers, and then I'll show you all of the correct answers. So the correct answers in the correct order. 2, 4, 1, 6, 7, 5. And these are the BCLS guidelines. Now, in disaster management, has anyone ever been somewhere and you've been in the middle of disaster and you've had to help or render aid? Okay. All right. I'm gonna utilize you if you don't mind. Okay. So, there's primary, secondary, and tertiary levels of prevention. As the nurse, you play a role in all three. Okay. Now, guess what? How many of you have already in healthcare? Okay. So, you all are the go-to. Okay? If there's a disaster, you're the go-to person. When they start asking questions, what should I do? What does this mean? You know, is this broken? What do you think? I'm having chest pain. Do you think it's a heart attack? You know, it just escalates. Okay? Now, having been in the middle of a disaster or emergent situation, as the nurse, you're gonna be looked upon. Even if you were the one that kind of sit back and wait now, you're the one that needs to step up, okay? So, having said that, and look, I know you're eager, I'm gonna ask you a quick question. Being a person that has been in a disaster situation before, what have you seen with leadership and were you a leader in the situation?
I mean, there's been more than one occasion, but it just depends on the situation. I mean, it depends on, you have to just take a quick assessment of what's going on, whether or not you need to take over that leadership role, step in. I mean, there's been times like, I don't know, it just depends.
Well, everything you just said is what I was looking for.
I was gonna say situational awareness is kind of like.
Exactly. Everything you just said is what I was looking for. You have to, you're assessing, you're the nurse. So our AdPod, you're continually assessing. For if you're doing something, you're assessing the patient, you're assessing your team, you're assessing the other staff members, you're looking around to see who needs assistance, who needs help. You might be doing tagging patients, and I'll talk to you about the tagging system in just a second. But when you're watching, and like he said, situational awareness, you're the nurse now, okay? And you are gonna be given roles, or either you might be the one delegating roles, okay? So when we look at primary, in the primary, secondary and tertiary, for primary disaster management, you're the nurse. You're doing the planning, you're assisting with training, okay? You might be assisting or doing a CPR class, okay? You're educating personnel and the public. That's primary. Getting everybody ready. So if it happens, they know what to do, okay? Secondary is the triaging of patients, and I might say casualties, okay? Treatment for the patients you can treat, and then shelter and supervision. Tertiary is the follow-up to things that we do as nurses for recovery assistance and hopefully to prevent future disasters if we can. Now the tagging system, you're doing your assessment, AdCom, okay? The red tag is for life-threatening conditions that need immediate attention, okay? You can help that patient, but they need immediate care. The black tag is for dying or deceased or catastrophic injuries, okay? If you see a patient and, look, their sternum is cracked open and you can see their heart beating and their eyes are already, and they're having that abdominal breathing, black tag, because there's nothing you can do, okay? All right? You might see their neck is broken, they get a black tag, unfortunately, okay? Because guess what? In a disaster, there are going to be so many people and casualties. You're going to have to move quick and make quick decisions based on what your assessment capabilities, okay? Now, the yellow tag, these are injuries with systemic effects and complications, and the green tag is for minor injuries with no systemic complications, okay? So the acronym we use when we're doing this rapid assessment is START. Simple triage and rapid treatment method, okay? You identify the walking wounded. You're gonna move them to an area where they can be evaluated later, okay? Because we need to separate them so we can see what else we have left, okay? 3-step evaluation: assess respirations, assess circulation, and assess their mental status, okay? Let's answer this question. So who are we gonna assess first, and what tag are we gonna give them?
3.
2? Okay. 2 is, and I want you to understand why. We're gonna assess 2 first, but think about it. They have full thickness burns, and we know that full thickness burns lose lots of what fluid quick. But where are those burns?
Oh, yeah, shit.
We haven't,
And what sits there?
To your heart.
we haven't covered that in med surg.
Y'all have it? Okay. The heart and the lung. But think about what sits in between those full thickness burns. Your heart and your lungs. Okay? So that will lead you to that correct answer. Okay? Now you have the 42-year-old with partial thickness burns to the anterior lower extremity and confusion. Confusion is the key word there. Okay? Confusion, because you're thinking about that neurological assessment. Then the 70-year-old, he's complaining of pain level 8 to 10 with a hand burn. It's his hand, okay? And then you have a 25-year-old superficial burn to the right anterior arm and lateral chest. Okay? The age and the location of the burn, okay, is why that person would be last. Let's answer this question. Correct answer is 4. They're gonna get a red tag because they need immediate surgery, okay? You can correct, they have an open wound to abdomen, okay? They have a deformed right femur, so they're gonna need, surgery. Heart rate 125, delayed capillary refill, respiratory rate is 32, and they're moaning. One would get what kind of tag?
Black.
Black tag, unfortunately. Okay. This patient scratches and scrapes to the head and face, who's limping and helping other people. Good. Okay. Now, bioterrorism. Can you name some bioterroristic agents? Anthrax and
Smallpox.
Okay. So those are the 2 that come to mind. Let's answer this question. no such thing as vector, so we could slash the trash, okay? Let's answer this question. Okay. So the correct answer, 1, 2, and 3, okay? So a combination of airborne contact and standard is recommended for smallpox. It's vector transmission, it's not. Droplet precautions are not necessary because smallpox is not spread by respiratory droplets, okay? From a person talking, coughing, or sneezing. Let's answer this question. Okay, okay. So if you see this rhythm, the first thing you're gonna wanna do is what? Check the carotid pulse, remember? You gotta assess your patient, you gotta manage the patient, not the monitor, okay? Bless you. The TN is caring for a postpartum client with a history of gestational hypertension who delivered 24 hours ago. Which finding or findings would alert the PN the client is exhibiting early symptoms of DIC? Select all that apply. So the correct answers are 1 through 4, okay? 1 through 4. Gangrenous toes are late time. Now, let's look at this question, and you're gonna select all that apply, okay? And you can just write it down somewhere in your book, so you'll have your correct answer of what you selected, okay? This patient is on Coumadin, and you're the nurse, you're instructed clients to avoid which of the following while taking warfarin. Okay, the correct answers are collard greens, not so much iceberg lettuce because it's just mostly water. Okay. Broccoli, Brussels sprouts, not green beans, they don't have a significant amount of vitamin K. Spinach, yes. Not zucchini, more water, and then kale, yes. Okay. Those are the correct answers. We are gonna keep moving on to chapter 5. You will be successful, okay? You have a lot of knowledge. I do have a signing sheet that some of you I don't think got to sign when you come back in for lunch. There's an AM column, put your initials in that, and then put your initials in the PM column, okay? Let's take a 10-minute break. Be back at 1:55, and we'll start chapter 9.
We're like, it's really good for us now. And then that last, so there's like 5 other people that didn't sign it too. So we went back there, was it Amika's room? So like all 3 of them, Amika, daughter, like it's someone else. I had to suffer for 30 extra minutes than you.
I'm gonna have to like share this with us because like somehow we got put on like right on here.
You got 3, yeah.
And then
It's too risky.
we have to do this and just kind of make sure we add areas and stages, all that good stuff, right?
You're not gonna always be able to get up and leave.
Oh,
You better not do that.
That's why you
and then I saw right here.
That's my true passion. Arguing.
I was gonna tell you, practice makes perfect or something. You have to build up to be able to handle those situations. In times where you can, you know.
Oh, like that. That's a little bit of give me 3 years. Get that baby in full swing. My mom used to like complain about being in a pause. I was like, well, I'm not about that either. She's like, on the daily, I'm a whole new brain.
Yeah, I know the opposite. Yeah.
I think it said.
When you get that mental shift, it's kind of it's crazy.
I feel it. I feel her
crazy.
growing. I feel a little bit red. She's still doing it.
Your mom.
My brain.
Oh. Looks like your mom never got it. You might want to try that right teacher.
No, not really.
I'm just joking. Yeah, no, you didn't have that. But I was like, you know, like, that's kind of like what just so you're aware. I'm just trying to have all your own time, but it's good to like other people.
That's why I think like rent a dang car till we're 25. Like you can do everything else but rent a car. Or like stay in a hotel. Certain hotels still like accrue. So just be over 25.
Really?
Certain ones that once again.
I mean, I guess.
That's the final like age point. Like once you're 25, you can do anything in your heart desire except for rent. But that's about the only other thing that has like an age.
I wouldn't trust a 25-year-old to run.
Oh, absolutely not. 25-year-olds run this class. Please.
Huh? Who are you talking about? Oh. No, because I was like, first of all, I mean, it would take me because I was like, well, some
So the chick I was working with, John,
Well, she knows that. She knows because I did it.
her mom had her at 14. Okay. But yeah, she thought that was like, she was ready to brought it up. She's like, I'm there too. No, I was like, I made it. She was just bragging that, I don't know why she brought that up.
Yeah, you said she tried to say that, like, the way her life is.
But most of the time, it's not the kids. It's the parent who has that kids are always half on. That's why kids fix the parent because no one can grow steps in.
Yeah.
Your mom is already raising a 14-year-old. kid too.
It doesn't mean that all kids
They don't really check it.
Yeah. No, I just mean like career-wise and stuff. And to be the mom, who it's harder for her to go to school. The kid is fine unless they repeat, which.
You are, no. Every time,
I said it really
I would say,
No,
cancel.
put the password in. This is at the end.
My phone is, it's not texting.
Oh,
So my phone is getting ready to send what I was saying.
Okay, now.
Yeah, I think, I'm trying to think about the people that are
Okay, so not
in
just
this
here, so read
situation.
it again. Make sure you, okay, now go to the home.
I know she's like
Don't go
the
in
mom I
here.
work with, like, I mean, she's getting her master's degree, but she had her son at 15. And her son is living a good life because she ended up making a good name for herself. They're best friends, you know. And then she, on the other hand, was a 15-year-old kid that everyone didn't talk to and got kicked out of all the clubs, you know.
I think it's a good thing to support.
You wanna do everything else?
Yeah, because grandma, she said immediately grandma stepped in.
What if you don't have that?
You don't?
Yeah.
Yeah.
You know,
Or I'm
You
kind of
got
off on
this.
them. The boyfriend or something. He was like,
Yeah, that's where stuff goes fast.
Yes, so I think that's what goes bad for you. If you did have a kid in that situation, things are still going south.
Yeah, but it's only
No, we're not
affecting one
doing
person in that present.
We doing another thing, you know, before we get there. No, we ain't doing it.
Stand up.
It's crucial. It's very important. I know mental it's so easy to be traumatized.
It's just a small thing too. I'm not hiding it. It's like they're especially stubborn child. He doesn't even get help afterwards. It's your choice to move and work through.
And I don't like that. I don't like that kind of responsibility.
Oh yeah, no. That's rude. That's what it is.
Because how dare you expect me to be in charge of this? No. We need to help people accountable. Let's go back to the very first day I was born, and every single person I came in contact with.
Hey, just what are they gonna do? Apologize?
We gonna start weeding people out. Like, oh God, you remember that thing? Yeah. We all gonna pay for the therapy together. We probably do like a little GoFundMe.
You can like, choose from the situation. All that they gave.